Welcome everybody out to Utah in the Weeds. My name is Tim Pickett, and this is episode 89. And today we're coming to you from, well, honestly, it's just me today. And you know why? Because there's so much going on at the legislation level, like so much going on in the space right now, that I felt like it would be a good idea just to throw in 20, 30 minutes of kind of some updates on the program, what's happening, maybe some of the ins and outs, nuances. I don't know everything that's going on right now in Utah, but I think it's worth talking about it and going through some of the bills, specifically Senator Vickers' bill, as well as Senator Escamilla, her bill on the floor. So before I get into that, I wanted to update you on a couple of things that were happening with Utah Therapeutic Health Center, utahmarijuana.org. And one of them is a new kind of educational partnership with a program called Gray Matters. And this is a program that launched recently, and I gave a speech at the Capitol, Utah Capitol, about it, about talking to children about marijuana use and cannabis use. And they're building educational resources and are going to be really working on helping parents, teachers, coaches, and kids have conversations with children about cannabis use and about the dangers specifically of cannabis use as a youngster. I don't want to, I'm an advocate of medical cannabis. I'm an advocate of legal access to cannabis, to THC products. But as you know from listening to this podcast, I hope I get this across, I'm not a fan of adult use programs, frankly. And I know that might be a little controversial, and some people are going to say, Tim, well, you're just not you're not a person who supports adult use because you make money as a gatekeeper for cannabis here in Utah. And that's just not true. I just think we are not ready yet for adult use. I think that it requires, I think there are a lot of people who can use cannabis in an adult way, maybe a recreational way, and a medicinal way without any further education. They know what they're doing. And they may not require a QMP or a medical provider's recommendation, frankly. I'm not opposed to that. Maybe there's 10, 20% of the population in that category. Maybe there's a middle ground where there's people who might benefit from talking to a medical provider about cannabis use. And then there's a third, 40% of people maybe who really need help learning how to use cannabis, because it's not an easy medicine to use. It's not like I can prescribe 10 milligrams of THC 3 times a day. And I know exactly how that's going to affect you and what that's going to do with you. If I gave that prescription, so to speak, or a recommendation to a patient, one patient might go out and not have any effect on their condition with 10 milligrams 3 times a day. And another patient may be completely disoriented, nauseated, paranoid, and just debilitated by that dose. And so it requires not only the person and the patient using the cannabis to keep a journal and be thoughtful and intentional about that product, but it also, I think, requires a medical provider to help guide that process. Plus, you have all of these issues with medication interactions potentially that we're getting new research about and are coming out, and help kind of what we call tip the scales in favor of the patient by guiding those choices of products and delivery methods and dosing that will help patients get through without too much trouble. So back to Gray Matters, I think that program is great. I think that kids should be educated. And like we talked about up at the Capitol, the Utah Capitol, kids will make good decisions if you give them the right information and you treat them with respect. And additionally, listen to the kids, right? Listen to why do you want to know about cannabis? Why do you want to use it? What's happening with you? So that's a great program. There'll be more about that. And of course, we'll have them on the podcast and talk all about that, but it's a good program. Uplift, donate at utahmarijuana.org/uplift. Donate, please donate. We're seeing patients. We have 72 visits scheduled already this year for low income and terminally ill patients here in Utah. Additionally, utahmarijuana.org, our YouTube channel, Discover Marijuana, is releasing episodes, videos every week. And I'm really excited about this next, this kind of series. It's about me and it's about Blake Smith. Get to know me, get to know why I got into this industry and this specialty in medicine, and a little bit more about me on Discover Marijuana. And Blake Smith, get to know him a little bit better. It was kind of fun. It was a little bit nervous, frankly, talking about myself and exposing that. Even me, who is in this industry and literally talks about cannabis and teaches people how to do this for a living, it's still I have that background of growing up in Utah and all of the nuances of our culture and conservative, and I have kids, and how much do you want to show the world and your kids, and how much it's maybe it's easy for you, but it's just still not easy for me. I'm not the guy who goes out and uses the Da Vinci right out on the back porch in front of my kids. I'm not there yet. So let's get into talking about these bills and what's happening in the Utah program. We will be having Rich Oborn on from the Department of Health once the legislative session is over and once these bills are complete. But right now, I want to bring these up for a couple of reasons. I think it's important because this is such a fast-moving industry and fast-moving program. I want to bring it up because I think it's important for us as a community of cannabis users and consumers and patients to be involved and hear what is happening and what is being decided by the legislature, who aren't maybe cannabis users or patients and who don't have the knowledge of the QMP community, the medical community. They're getting information from all these sources, but they're really making the decisions. So let's get into this. I'd like to start with Senator Vickers' bill. It is Senate Bill 190. Now, so here's my understanding. I'm not an expert at the legislature. What I do know is Senator Vickers will write the bill, and then it will go through committee. It will pass out of committee, and then it will, once it passes, passes out of committee, and then it goes, I think, to the floor, the Senate floor. Once it passes the floor of the Senate, then it goes over to the House of Representatives. And so each of these bills has both a Senate sponsor, Senator Vickers in this case, and a representative sponsor, what's called a floor House sponsor. And in this case, I believe it will be Representative Ray Ward. Currently online, there's no listed House sponsor. But the House tends to like Representative Ward to do these. He's a medical provider. He's a family practice physician here in Bountiful, Utah. He's actually my representative, but it hasn't got a House sponsor yet. So Senate Bill 190, it's online at le.utah.gov. You go search for it, and you can find the bill there. He introduced it first, and then there is what's called the substitution now bill for that. So it's when they do an update. And let's just go through a few of these updates that I think are interesting. Senator Vickers' bill focuses on the hemp industry specifically and restricting products that are psychotropic and psychoactive outside of the medical market. It was one of the big goals of some of the constituents and some of the groups. I think that I can't speak for them, but certainly the growers in the medical side of things, the processors and the retail operators, were definitely pushing for more restriction on the over-the-counter market, and some patient advocacy groups as well. Utah Patients Coalition specifically, I believe, was, and we'll talk to Desiree Hennessy about this as well. We're trying to get this restricted because, and we've talked about this before on the podcast and on my YouTube channel, Delta 8 THC. So you have multiple deltas of THC. Delta 9 THC is the one that we are commonly, we associate with getting high, right? Delta 8 is produced in the plant, but at a very low amount. There's Delta 10, Delta 11. But Delta 8 is something that is usually created by converting CBD into Delta 8. And Delta 8 is psychoactive. It is less head high, tends to produce a body high, more than a head high, tends to absorb better in the gut and the periphery, right? So CB1 receptors are in the nervous system and the brain and the spinal cord, and that's what really gets you high. And then there's these receptors all over the body. There's a lot of these receptors in the gut, CB2 receptors, and they're gonna interact with Delta 8 more. So a lot of people with abdominal pain find Delta 8 to be a little bit better. But there over the counter, you can buy a lot of Delta 8 products over the counter at vape shops specifically. And there's been a lot of kids. There's some news articles in the fall about somebody using some Delta 8 products and having really, really bad reactions. I think the big concern for me and for the Medical Cannabis Advisory Group that I am involved with, which is some pharmacists and providers, is that there's up to 5% of unknown chemical byproducts in these products. So that poses a risk to patients when you don't know what up to 5% of these products are. And the way you get CBD to convert to Delta 8 can be done pretty cleanly, but also can be done with some garage organic chemistry. And that leaves patients really in a bad position, taking products that potentially could harm them with these unknown chemical byproducts. So Senator Vickers' bill deals with this pretty specifically. It also talks about distributing and selling industrial hemp products, stuff like that. Mostly deals with things that potentially the Department of Agriculture would deal with. So let's look at this. So the big issue is that we're gonna change the 0.3% THC, right, to a combination. So we're going to combine the 0.3% by dry weight, okay, and then we're going to add. It contains a combined amount of total THC and any THC analog that does not exceed 10% of the total cannabinoid content. So what that means is the specific piece of that is THC analog. So Delta 8, Delta 9, Delta 10, all of these psychoactive THC analogs are removed. Okay, they're basically going to say you've got a total THC content of 10% or less, and you also have to live by this 0.3% by dry weight. So let me put that in perspective. If you were buying a product, if you bought a 1 liter drink, and you wanted to put as much THC in it as you could legally and sell it over the counter, you could get up to 3 milligrams of Delta 9 THC in a 1 liter drink. So that's a reduction from the condition now, which is only dry weight, 0.3% on a dry weight basis. Now you're going to have 10%, less than 10% total cannabinoids plus the dry weight issue. Okay. Now in that liter product, you would have to have, 10 times the THC of something else. That's pretty easy. Put 30 milligrams of CBD in there, or CBG, whatever, and you could do that. And then you could drink a 3 milligram Delta 9 drink and buy it at the vape shop. So certainly those products will be developed if this bill passes out of committee. One of the issues we discussed in our cannabis advisory group is some states have gone to a milligram type recommendation to keep it at less than 2 milligrams per serving, so that they don't get this. Because, I mean, frankly, if you put 5 gallons of, product, if you sold a 5-gallon bucket, you could put a lot of THC in there. No, I don't think a kid's going to drink 5 gallons of whatever it is, but I think you get my point. So the two things are important in this bill right here are THC analogs. So they're basically cutting out defining the definition of THC to include all of the deltas. And then the second thing is reducing this. Talking to a person who develops some of these products today, this will eliminate, he believes that this will eliminate national brands, multi-state brands from selling those products, those types of hemp-based products in Utah. And you'll be limited to Utah-based manufacturers, to get these types of products. The second issue in the bill is the drinks. Currently, the law says that you can sell a liquid suspension. That has been somewhat controversial because there has been tinctures. A tincture is essentially an oil that you put THC in, and then you unscrew it, and there's a little dropper, and you can measure out your dose. And as a patient, it's a very good way to dose out THC. And there has been some companies to produce drinks in cans and drinks. And their argument was, hey, it's a liquid suspension, right? The tincture is a liquid suspension. NyQuil, right? Nobody would argue that NyQuil isn't a liquid suspension. It's just in a bigger bottle. And so why couldn't you do a drink? Of course, Select from Curaleaf has a drink additive, which is a liquid suspension that you put a teeny tiny, liquid, and you just add it to a drink, add it to any drink that you have. And that, of course, I don't think would get affected by this bill, but this bill limits a liquid suspension to 30 milliliters, which is the same amount as a tincture. It's essentially restricting no drinks, absolutely no drinks would be sold in Utah if that line passes. The THC analog, it also defines THC analogs, which means a substance that is structurally or pharmacologically substantially similar to or is represented as being similar to Delta 9 THC. So that, again, Delta 8, 9, 10, 11, all those. It also defines what is not a THC analog, and includes a few of the cannabinoids that we can buy over the counter: CBC, CBL, CBD, CBDV, CBE, CBG, CBGV, CBN, CBV. I'm not going to go on and on. That's literally all the ones that are listed in the bill. Total THC, again, the sum as calculated as all of that jargon. Next, I think this one is kind of funny. It makes all retailers of these products list them as a hemp product and not as a cannabis or medical cannabis product. And I think that's kind of funny. Come on, right? Like, that just seems to me to be the medical market's way of saying, this isn't cannabis. That's partly why I use the word marijuana, frankly, because nobody questions what I'm talking about. And cannabis is a little confusing because, you don't know hemp versus cannabis now is a discussion point, apparently. So a couple of other issues in Senate Bill 190. allowing for a research university. I think the only research university in Utah is the University of Utah, to do more research and to operate as a lab. This will help do some studies, and I think this is pretty cool to allow the University of Utah to be involved in the testing, because because it also includes a hospital. So, this potentially opens up the door to a little bit of clinical research. There's a few programs around the country that do clinical research, not many. And hopefully the University of Utah will get into that. And then there's some language about, there's been some movement in the ownership of the growing licenses. For example, Curaleaf purchased Trike. So now Curaleaf is a vertically integrated organization here in Utah. They grow, they process, and they have their pharmacy in Lehi. And I believe also Zion Medicinal has purchased Bloom Medicinal in Cedar City, and so now they are vertically integrated. So there's some interesting language about notification to the state if ownership of these things change. There's some safety clarifications in labeling here in this the bill. Always trying to tweak things. Rich Oborn said it to me best the other day. Compromise kind of breeds complexity, and so all of these compromises, they either made it more complex and they're simplifying it, or we are now making it more complex. Changes a little bit of rules for the Department of Agriculture, who can make rules, and in identifying each derivative or synthetic cannabinoid is a derivative or a synthetic cannabinoid. So a little bit of labeling issue between derived cannabinoids and synthetic cannabinoids. There was some controversy on, and there's some opinion within the pharmacy community about labeling synthetic cannabinoids. Delta 8 can be considered a synthetic cannabinoid or a derived cannabinoid. And some people consider Delta 8 a derived cannabinoid. So a little bit of clarification there. I don't know what's best. I think it's hard because you really have to educate the public and educate the patient to be what they're taking. I'm a big fan of as much transparency as possible and as much testing, frankly, as possible. So the gelatinous cubes, there was the issue with gelatinous cubes being coated with sugar, being too much, too enticing to children. And they changed that. They allowed sugar coating on those. And really reason is because it allows those things not to stick together. So it really didn't change the rules, other than it made it easier for producers to, I think there was some discussion that they were going to have to wrap each gummy individually. And I've consumed gummies where they're coated in sugar, and it is a little bit better. One of the big problems that you have in cannabis gummies and gelatinous cubes, they're still keeping that language, don't worry, is that they melt together at any heat. The melting point is really low for these, and they stick together. So adding sugar coating, not making it, an edible or enticing to children. But I think that was a good little tweak. And then if I read this right, I believe that the legislation is kind of putting a deadline on this provisional card. So there was a discussion and a passage of this provisional card. So currently, when you get a medical patient card, it takes the Department of Health, a few days, up to 15 days by statute, to issue that card. And I think this puts a deadline as of September 2022. You better have that provisional card ready to go. So that would make it such that a patient applying for a medical card would get it immediately based on the provider's recommendation. And that provisional card would be good for 60 days. And then the card would convert to a normal card. So no additional meetings, just better for the patient because they get their card immediately. That way, if you come see me in Bountiful, say in the same building as the Wholesome Co. dispensary, that the old car building there by Costco, you could literally walk out of my office and walk into the pharmacy and buy product. That's important. There's a lot of patients who drive a long way, frankly, to do that face-to-face visit. And it should just, we live in the digital age. Come on, that should have been done, years ago on day one. But the EVS system, who we should get on to the podcast is the EVS producer, like the developer, right? We need that person. Get them on. We could chew their butt for building such a crazy program. Speaking of crazy programs, so a registered pharmacy agent, right? If you're in the pharmacy working, you do not have legal access to the EVS system. How crazy is that? And I don't think a lot of people understand that. No, really, the person selling you the medical cannabis behind the counter, they cannot access the EVS system and see your purchasing limits. The pharmacist is the only person. So Vickers bill adjusts that, gives the pharmacy agents requirements for some privacy, essentially HIPAA training, medical HIPAA training, which I don't think a lot of them would have, right? I don't think a lot of them come from the medical industry. So it gives them some training on privacy because that is paramount, and then allows them to have what's called proxy access to the EVS system. And we have that in the medical side. We have our medical assistants are able to log in and change things in the EVS system on our orders. That's pretty standard in medicine, right? Like I can say to my MA, hey, will you call in this prescription for this patient? And that can be done on my orders. So that's a nice little update there. I think that's pretty much it. As far as the big things, I think it's kind of interesting to go through this bill and kind of see what tweaks they have and things like that. So let's move on to Senate Bill 195, Senator Escamilla's bill. Mia is a Democrat, and she also has a bill that doesn't have a House sponsor yet, but again, similar to the other one, we anticipate that Dr. Ward, Representative Ward, would be the House sponsor. Her bill passed out of committee as well and has a substitute amended bill here. And it covers different things, more things that are related to the Department of Health, advertising specifically, and QMP renewal process. But the advertising thing was kind of a controversial, that was kind of the controversial piece of her bill. So let's talk about that a little bit. There was this weird thing in the original bill that did not allow a QMP to even say you're a QMP, right? Which just isn't really practical. So they've made it a little easier for a QMP to say, hey, I recommend medical cannabis. You cannot, though, you can't advertise for a specific condition that you're treating, like that you're going to help a specific condition. You can't make a claim. So this clarifies that you cannot make a claim. It also it eliminates the ability to use terms that are related to recreational marijuana. Okay, so I'm going to go through these terms for a minute. And I look, here we are. We live in Utah. You can't use the word weed, pot, reefer, grass, hash, ganja, Mary Jane, high, buzz, haze, stoned, joint, bud, smoke, euphoria, dank, doobie, kush, frost, cookies, wreck, bake, blunt, combust, bong, bud tender, dab, blaze, toke, or 420. Okay. I don't know. Were you really getting into the weeds there, right? We really are. Legislating words we can use. I don't know. It's a little crazy. So the controversial thing with the advertising was the discounts. So they were going to restrict the discounts that you could use. You couldn't provide a discount. You couldn't provide a coupon. Couldn't provide anything like that. So, and then you couldn't reach out and tell patients about a coupon or a discount or a promotion. So that's something that these pharmacies, it's the weird part about medical cannabis programs, because it's kind of a in between a true medical pharmacy and a retail adult use or recreational pharmacy or dispensary, because it's not like you get a text message from your regular pharmacy like, hey, metoprolol's 25% off, come stock up on, metoprolol, or hey, Zofran today is, today only, we're going to have an event. Now you can't use 420, but we're going to have an event, and so Zofran's going to be, $2. But in cannabis, we do that. So they wanted to really restrict that. One of the problems with that was there's subsidy programs, for example, like my Uplift program, and that that offers a 25% discount to terminally ill patients. Hello, we need that. We need that to stay, and we were able to fix that piece, but it's going to restrict some advertising. And I think the billboards that you see of Wholesome are going to be coming down for that, based on this rule. But if you want those promotions, I think what's going to be key, and we'll follow up with you on this, what's going to be key is if you want access to those promotions, you're going to have to opt in. So you're going to have to join the email list at Block, Curaleaf, Deseret Wellness, Wholesome, Bloom. And once you opt in, then you'll be able to get those coupons and those discounts. And those, what they're going to call them subsidies. So updating the advertising standards. Now, one other issue, and Senator Escamilla has done a really good job here with the hospice board. So they're saying she wants every hospice program to have at least one QMP available. And this has been something that we've noticed. We do Utah Therapeutic Health Center. We do home visits for people who can't get to the clinic, and we've actually been working with some hospice companies, and we treat palliative care and hospice patients specifically for cannabis. So I think this is a step in the right direction. Every hospice, whether or not they recommend cannabis at all, they just want to require that somebody is able to recommend cannabis. The other interesting thing about Senator Escamilla's bill is it will allow an acute pain diagnosis. So it's actually going to add a 16th qualifying condition. And that is a way for, say, a surgeon who is going to replace your knee to give you a 30-day medical cannabis card for that acute pain episode. And then, of course, you could convert that to a long-term card if you qualify and the QMP allows that. That, I think, is interesting. And to be honest, I think that's a little complicated. I didn't personally think it was necessary. I think that if you have pain in your knee and you're going to get it replaced, you qualify for a card anyway. So why muddy the waters with this weird 30-day card? But the point, I think, being we're trying every single little way to expand the program that we can in the political climate that we live in here in Utah. So interesting acute pain kind of qualifying condition there. The language of that bill is going to include pain that is expected to last for 2 weeks or longer for an acute condition, including a surgical procedure for which a medical professional may generally prescribe opioids for a limited duration, subject to, section blah, blah, blah. So from a research standpoint, this is not really based on research, in my opinion, for acute pain versus chronic pain. Again, I think that if you need that surgical procedure or something, and you probably qualify for a card anyway. I get that people really, what I do support in this, what I absolutely do support is people who don't want to use opioids, and there are a huge growing number of people who just don't want to use synthetic pharmaceuticals, and they want to use something natural. And in that case, this is really spot on, right? Because what are your other options other than Tylenol and ibuprofen? So this, I agree. this is a definite step in the right direction. Adding QMPs to these boards, I think, again, really good step in the right direction. Whether or not those providers recommend cannabis doesn't really matter, frankly. It's you're making them get the education that I think will in the future lead to more cannabis recommendation and the public destigmatizing cannabis as a medicine. One of the last things she does is change the Cannabinoid Product Review Board, the name, to the Cannabis Research Review Board. Interesting why we think we need to do that, but maybe that'll end up being the thing that makes the difference. And it also talks about the Research Review Board, kind of how they're chosen. Now, one thing I would love to see on the Cannabis Review Board and the Compassionate Review Board, frankly, is including more medical providers. As a physician assistant, as a PA, and knowing and employing and working with nurse practitioners, leaving us out. We really do run the program. Frankly, there are more PAs and NPs by far than MDs that are in this program as qualified medical providers. Nobody got more education than anybody else, medical school, PA school, nurse practitioner school, about cannabis, and excluding us, I don't agree with it, but I've never been a member of the club anyway. So I guess this doesn't change that. Helps students and schools when they have a student that is using medical cannabis. For example, let's say an 8-year-old with severe autism, and they found that a tincture of cannabis is really, really helping. This helps the school, and it helps legislate protections for that student, so that student doesn't have to be taken off of school grounds to get their medicine. They can have that medicine right there at their school. And I believe there's also some protections there, for the nursing staff who is administering this, because frankly, it's a federally Schedule 1 illegal drug still, right? So that brings up some anxiety for school districts. I was involved in a program about that, and boy, there's a lot of anxiety around that. Schools, nurses, kids. I mean, you've got to really, that'd be rough, right? So a couple of other higher education medical training also requires some QMPs to be involved in medical training. Again, just kind of forcing education. And I like this idea. I don't think you need, as a provider, you certainly can decide whether or not you want to recommend medical cannabis to patients, but you should be required to know about it, to know about the Utah program, especially if you're educating other medical providers, like that hospice thing. And then the last thing that was kind of discussed in the interim, I had a meeting with Senator Vickers in the fall about renewing patient medical cards, and we'll see. I'll have an update about that. That's what we are proposing, and what I think is necessary in the program myself is to allow for medical providers to cover for each other. For example, if I have a partner, QMP, who goes out on maternity leave for a few months, what happens to those patients? Right now, if my panel is full, those patients have to go shop for another QMP, and that's just inappropriate for medical care. Those patients should be able to be seen by me and recertified under that my partner as a provider, and then she comes back and she can resume care of those patients. That's just a continuity of care issue. There are other drugs that are like this in the world. Accutane, is one of them, where providers kind of share responsibility and are limited in the number of prescriptions they can write. And so it's not outside of normal medical practice to cover for your providers. There is some concern that allows for some manipulation in the program. And so I think that, making those, even if you have to make those visits face to face and not do them telemedicine, fine, keep those providers here. The important thing is really continuing care for those patients and, getting them the help they need so that they don't have to go doctor shop when a provider leaves town for a while, gets sick on maternity leave, or otherwise is kind of unavailable. Continuity of care is a big issue in the cannabis program. And I think that it's, not only cost is an issue, but I think that if you're forcing patients to shop around because of patient caps, then that's, of course, patient caps are there so that you don't have cannabis card mills. And the bad side of patient caps is you end up with this situation where patients have to doctor shop if a provider isn't available to renew that card. So we should keep those patients within the same medical practice. Now that has been, Senate Bill 195, Senate Bill 190, just, going through them. I don't know whether or not you're going to love this episode. I think hopefully there's some people out there who really appreciate this. And I certainly love to learn about it and stay informed. And really, I'm trying to help you stay informed about what's happening in your medical cannabis program here in Utah. I'm happy to do it. I'm happy to be the one who tries to figure all this out for us and deliver the information. Utah in the Weeds podcast. We really are. We've got a complicated program, but it seems to work in a lot of ways, and we all want to make it better. If you want something changed in the law, of course, now probably isn't the best time to do that. These things are already in motion, but in the summer and in the fall, that's when to really get involved and help the senators and the legislators understand what's going on. So we'll be doing more research and really trying to get the public and the patients involved more and more as we go and as this program develops. Thanks for listening. Please subscribe to Utah in the Weeds on any podcast platform that you have access to. My name again is Tim Pickett. I love medical cannabis as a specialty. I've really enjoyed this whole journey with you and learning about it and helping people feel better. It's been very, very rewarding. So stay safe out there, everybody.